طيب يلا يلا، أنا عندي لايف شغال هسه، يلا برجع لك وقت ثاني.
طيب.
أحضري في اليوتيوب.
طيب.
Hello everyone. Today we will speak about renal tumors part 2. Renal cell carcinoma or RCC. The risk factor for renal cell carcinoma include tobacco smoking, obesity, hypertension, chronic renal failure related with dialysis, in adult polycystic kidney disease, family history, genetic risk factor, and exposure to chlorinated solvents, especially trichloroethylene. Avoiding obesity, smoking, hypertension might decrease the risk factor for developing RCC. The presentation, the most common age of presentation for RCC is 60 to 70 years of age. RCC is often asymptomatic. Symptoms include symptomatic symptoms include flank pain, hematuria, weight loss, fever, and sweats. Signs include flank mass, hypertension, and new varicocele, especially the rapid onset varicocele, plus the sign of paraneoplastic syndromes. Also, the classical triad is associated with RCC, which include flank mass, flank pain, and hematuria, which is now rare because the tumor are often detected incidentally or the patient usually asymptomatic. So this is incidentally at the lowest rate. The presence of the classical triad signifies advanced disease. Here we have classification of RCC. We have cell cytoplasm type, and we have also electron microscopy, and we have colloidal ion stains, binucleate, nucleic outline, and cell origin of each of these. We have oncocytoma and we have chromophobe RCC. The oncocytoma cell cytoplasm type is 1, so it is granular eosinophilic. In chromophobe RCC, which is actually have 2 granular eosinophilic or pale. This is the cell neoplasm, have 2 cell neoplasm, but the oncocytoma have 1 cell cytoplasm types. And the oncocytoma have a rare microvesicles and many mitochondria. This is in the electron microscopy of cytoplasm. In electron microscopy of cytoplasm show many microvesicles and some mitochondria in chromophobe RCC. So here we have many microvesicles, and here we have rare microvesicles and many mitochondria. Many mitochondria in leukocytoma, and in chromophobe RCC have some mitochondria plus many microvesicles. Also, leukocytoma have a Hales colloidal ion strain negative, compared with chromophobe RCC have positive Hale colloidal ion strains. The binucleate usually are common in chromophobe. Chromophobe RCC have binucleate compared with leukocytoma, which is have rare binucleate. The nucleus outline is smooth in leukocytoma and it is irregular in chromophobe RCC. The cell origins in oncocytoma is collecting duct, also as well as in chromophobe RCC, it is collecting duct. I hope this classical classification feature for each oncocytoma and chromophobe RCC is clear. Again, oncocytoma have one cell cytoplasm and it is have many mitochondria with negative Hale colloidal ion strains, and also have smooth nuclei outlines, and it is collecting cell in origin, compared with chromophobe RCC have two cell cytoplasm and also have many microvesicles, and it is positive for Hale colloidal ion strains, and it is common have binucleate this binucleate, and also it is irregular outline nucleus with its actually cell origin from collecting duct. This is the features of each type. Again, clear cell RCC, the characteristic pathology is clear cytoplasm. Papillary, the characteristic pathology is papillary architecture. Chromophobe, the characteristic is distinct cell border and a perinuclear halo. In collecting duct, it's the characteristic pathology is hobnail cells, tumor located in the medulla. This is collecting duct. The clear cell commonly have common cytogenetic loss of 3B, compared with papillary have polysomy 7 and 17, a loss of Y or MYT mutation. This is papillary, so it is a common cytogenetic is polysomy 7 and 17, a loss of Y or MYT mutation, compared with chromophobe, which have multiple chromosomal deletions, and it is actually this is a cytogenic importance or cytogenic features for chromophobe. It is multiple chromosomal deletion, but the collecting duct have no clear cytogenic features. Compared also clear cell origin from proximal tubule. The clear cell usually come from proximal tubule, and papillary it is also come as well as clear cell from proximal tubule. Comparing chromophobe with collecting duct, which both come from collecting duct. So the disease associated with clear cell include von Hippel-Lindau and TC3 and BAP1, and also Cowden cytech mutation. All this is disease associated with clear cell. The chronic renal failure and hereditary leumatosis, RCC, and HB RCC, all this is associated with papillary. The chromophobe, this is associated with Bright-Hogg-Dubé syndromes. This is chromophobe. And the collecting duct, specifically the medullary one, it is associated with sickle cell disease or sickle cell triad. So the malignant potential for clear cell, it is moderate, and papillary type 1 and type 2. Type 1 is low, type 2 is high, and also chromophobe, this is low, and collecting duct is also high as papillary type 2. This is abbreviation as we mentioned it. Let me summarize for you the cancer associated with each type of RCC. Clear cell associated with von Hippel-Lindau, and also translocation of chromosome 3, and also BAP1 syndrome and Cowden and check mutation. This is with clear cell. Papillary associated with chronic nephrite and also with HL or hereditary leiomyomatosis, RCC, and also hereditary papillary RCC type 1 syndrome. This is with papillary. The chromophobe associated with bright Hoop-Dubé syndrome, and collecting duct associated with sickle cell disease. This is the classification. This is another comparison between clear cell and angiomyolipoma and oncocytoma. The clear cell is malignant, angiomyolipoma is benign, and oncocytoma is benign. Origin of the clear cell: proximal tubule. Angiomyolipoma is fatty, and collecting duct is collecting duct. Oncocytoma is collecting duct. The gender in clear cell is male more than female, and angiomyolipoma female more than male, and also oncocytoma male more than female. Average age 60 for clear cell, 40 to 60 to angiomyolipoma, 40 to 60 for oncocytoma. Side left and right equally in clear cell. In angiomyolipoma, right is common compared with left, and oncocytoma it also have equally or between left and right. It is equal as clear cell cancer. Gross color, the golden yellow, this is a clear cell, so golden yellow, or yellow green, this is angiomyolipoma, and mahogany or tan, this is oncocytoma. Common macroscopic features: solitary, this is usually solitary and unilateral, this is solitary and unilateral, this is centrally scarf, solitary unilateral oncocytoma. The common microscopic feature: clear cell, it is clear cytoplasm. In angiomyolipoma, the common microscopic is fat, smooth muscle, blood vessels, and HMB45 positive. And oncocytoma, this is actually nest of eosinophil, and the hypervascular, it is most hypervascular, or it is actually angiomyolipoma is also most hypervascular compared with oncocytoma have few vascularity. Capsule, pseudocapsule for clear cell, and angiomyolipoma have no capsule, and oncocytoma has fibrous capsule. Necrosis often in clear cell compared with angiomyolipoma and oncocytoma, which is rare. Mitosis, clear cell is common have mitosis, but others, angiomyolipoma and oncocytoma, is rare to have a mitosis. Disease associations, it is von Hippel-Lindau and TC3 and BAP1 and Cowden and check mutant tuberous sclerosis with clear cell. Tuberous sclerosis with angiomyolipoma, and bright Hoop-Dubé syndrome with oncocytoma. Paraneoplastic, up to 30% of clear cell have paraneoplastic, but angiomyolipoma and oncocytoma have no paraneoplastic syndrome. Ultrasound, this is hyperechoic, also as well as other angiomyolipoma and oncocytoma also is hyperechoic. CT scan enhance in all of these renal masses enhance, but remember for angiomyolipoma is negative. A Hounsfield unit is minus 20 to minus 80. All is enhanced, but here it is minus 20 to minus 80. Arteriogram, venous pooling, AV fistula, new vascularity, accentuations of capsule vessels. Remember, the angiomyolipoma is hypervascular, and arteriogram show spoke wheel patterns of the tumor arterioles, lucent rim of the tumor capsule of angiomyosarcoma, as we showed for you previously. It's known as spoke wheel pattern of the tumor arteriole, lucent rim of the tumor capsule. Spoke-wheel and lucent trim of the capsule on arteriogram are not specific to oncocytoma and can be seen in RCC as well. Usual treatment for clear cell carcinoma is excision, and angiomyolipoma is observed or excision accordingly, or immobilization. For oncocytoma, excision is best choice. Diagnosis is pathological, radiological, and pathological for angiomyolipoma and pathological for oncocytoma. The paraneoplastic syndrome associated with RCC, approximately 10 to 20% of the patients with RCC have paraneoplastic syndrome. And in this slide here, we mentioned that up to 30% of the patients with clear cell carcinoma, renal cell carcinoma have RCC, up to 30%. But here, to specify this, approximately 10 to 20% of the patients with RCC have paraneoplastic syndrome. This syndrome are reversible with the tumor resection. Paraneoplastic syndrome include elevated ESR or erythrosedimation rate, weight loss, cachexia, fever, anemia, hypertension, and hypercalcemia. Hypertension from renin produced by the tumor, and hypercalcemia from parathyroid hormone like peptide substance produced by the tumor. And Stafford syndrome, this is hepatic dysfunction as paraneoplastic, which is reversible hepatitis associated with RCC that has not metastasized to the liver. Elevated alkaline phosphatase and polycythemia from erythropoietin produced by the tumor. So this is the primary RCC size and risk of metastasis at presentation. If the size is less than or equal to 3 cm, it is less than 4% risk of metastasis at presentation. If more than 3 or 4 cm, 7% at presentation. And more than 4 to 7 centimeters, it is 16% at presentation. More than 7 to 10 centimeters is 30% at presentation, and more than 10 to 15 centimeters is 41% at presentation, and more than 15 centimeters is 51% risk of metastasis at presentation. That include N1 or M1. Integrated of staging for renal cancer. The UCALA integrated staging system is known as UISS, the TNM staging. This is UCALA. It is integrated staging system. It is abbreviated in USS. UISS. This is used for TNM staging to stratify patient into category that predict survival after treatment. We have 4 months or 4 months grade or Eastern Cooperation Oncology Group Performance Status, or known as OG or ECOGBS. This is Eastern Cooperation Oncology Group Performance Status, or ECOGBS. So the UISS, this is for surveillance. Okay, so this is the predicted survival after treatment. We will use 4 months and Eastern Cooperative Oncology Group Performance, or known as ECOG. This is for survival after treatment. For staging, TNM staging, this is the UCALA integrated staging system use the TNM staging. The UIS is also for survival based on the grade. The grade, high grade imply a worse prognosis. Chromophobe, collecting duct, renal, medullary, and unclassified RCC are designated as high or low grade. Foreman grade is not appropriate for this. So papillary RCC Foreman may be used, but histological subtype 1 and type 2 also should be reported. The clear cell RCC Foreman grading should utilize. Foreman nuclear grading is used for clear cell and papillary RCC, and it is based on nuclear characteristic size, contour, and nuclei. Mitotic activity is not considers the tumor is assigned the highlight identified grade. If spindle shape sarcomatoid cells are present, nuclear grade 2 is assigned. This is the Forman nuclear grade 1 and 2 and 3 and 4. Grade 1, this is the nuclear size is small, compared with grade 2, nuclear size is medium, compared with grade 3, the nuclear size is large, compared with grade 4, the nuclear size is large as grade 3, and the nuclear size in a small one, it's grade 1, it is about 10 micro, compared with medium, which is 15 micro, and the large is 20 micro, this is for 3 and 4. The nuclear for grade 1 is round, small, uniform, and no predominant nuclei at 100 micron. So this is the at 100 low power magnification. So grade 2, this is the medium, as I mentioned, the nuclear size medium, it's about 50 micro, and the nuclear is minor irregularities, which is actually not appear at 100 time low power magnification. So the grade 3, this is large and major irregularities if more than 100 or 100 time low power integration magnifications, it is appear. This is a prominent nuclei. 4 is also as well as 3, it is appear prominent at nuclei at 100 time low power magnificence. Nuclei may also seen with high power magnification more than 400. So this is known as Forman nuclear grade. Forman, this is for, as I mentioned, for clear cell and papillary RCC is based on nuclear characteristic, and we mentioned that size, contour, and nuclei, as we see in this, the nuclear size, contour, and nuclei at 100 low power magnification. And also high power magnification at 400 is also seen. This is the medium. The medium can see it in this high power magnifications with this nuclei size of 15. It will be seen by this magnification of high power 400 times. This is the grade 1. As we mentioned, that the grade 1, the nuclei is small. If you look, the nuclei is small. Okay, so the nuclei is small. It's about 15. It's about 10 micro, sorry, and it is small, round, smooth, uniform. If you look here, it looks small, round. The cell is more round and with same uniform, and it is not appear on 100 magnification, low power magnification. The grade 2, if you look here, the nucleus is actually minor. This is the nucleus with minor irregularities, and it is medium, about 15 micro, and it is seen only in 400 time high power magnification. This is the grade 2. Grade 3, this is actually have a large nuclear size. It's about 20 micro, and it's major irregularities, not minor as 2, and it's seen under low power magnification. This is the grade 3. The grade 4, this is have characteristic large nuclei, which is actually about 20 as well as 3, and have major irregularities, often multilobulated and polymorphic. As you see here, the nuclei is not clear as well as others in this. This is round, smooth, uniform. All this is in grade 1. In grade 4, it is not possible to differentiate the nucleus. So that is polymorphic with major irregularities as well as grade 3. And it is also possible to see it by low power magnification. We come to the stage American Journal classifications of cancer. The following, this is a TNM classification, refer both the clinical and pathological staging. High stage or higher stage imply a worse prognosis, and this stage systems apply only renal cell carcinoma and not to other renal tumors. The primary tumors, we have TX, T1, the T1, the TX, the primary tumor cannot be assessed or no evidence of primary tumor. The T1, this is divided to, the TX, the primary tumor cannot be assessed or no evidence, and T1, the tumor less than 7 centimeter in greater dimension, limited to the kidney. This is the T1. The tumor must be limited to the kidney, and it is less than or equal 7. We have T1A and T1B. According to the size, T1A, the tumor is 4 centimeter in greater dimension and limited to the kidney as well as general T1. The T1B, here the tumor is 4 centimeter, but not more than or equal 7. If the tumor equals 7, this is not T1B. Okay? If the tumor more than 7 is not T1B. So 4 centimeter to 7 or to less than or equal 7, this is actually less than or equal 7, this is T1B in greater dimension, also limited to the kidney. This is stage 1, this is T1A, and here the tumor, it's not greater than T1A, not greater than 4 centimeter, and no lymph node in 0 or X, no regional lymph nodes, no MITs, and it is limited to the kidney. As you see here, the tumor is less than 4 centimeters, less than or equal 4 centimeters, and not actually limited to the kidney. And this is T1B. Here is more than 4 centimeter and less than or equal 7. This is the BT1B. No lymph nodes, no MITs. The T2 tumor more than 7 centimeter in greater dimension and limited to the kidney. T2A tumor 7 centimeter, but not more than or equal 10 centimeter in greater dimension and limited to the kidney as well as T1. T2B tumor is 10 centimeter, limited to the kidney. Here it is 10 centimeter and limited to the kidney. Here it is tumor more than 7 centimeter in greater dimension and limited to the kidney. This is in general. T2A is 7 to equal or less than 10 centimeters in greater dimension and limited to the kidney. And this is the T2A, BT2A, that's more than 7 and less than or equal 10 and limited to the kidney, as well as T2, this is T2A. The T2B is more than 10 centimeter and limited to the kidney. The T3, the tumor extended into the major veins or perinephric tissue, but not into the epislateral adrenal gland or not beyond the Garrota fascia. T3A, the tumor extended into the rest vein or it is a segmental branch or invade the Bylphy calyceal system or invade renal and or renal sinus fat, but not beyond the Garrota fascia. The T3B tumor extended into the vena cava below the diaphragm. T3C, the tumor extended into the vena cava above the diaphragm and invade into the wall of the IVC. This is a stage 3 RCC. This is stage 3A. Stage 3A, the tumor is any size, invades segmental vein or renal vein. The 3A tumor is any size, but not invade the renal sinus. Invades the or perinephric, but not beyond the Garrota fascia, not beyond the Garrota fascia. Okay, so this is a 3A. Again, we have T3. This is extended to the major vein, perinephric tissue, but not in the epislateral adrenal gland. Let us make this clear again. T3, the tumor extends to the major vein, for example, the renal vein or perinephric tissue, but not into the ipsilateral adrenal gland and not beyond the growth fascia. The T3 divided to A, B, C. The A, this is the tumor extended into the renal vein and it is segmental branch. So here, 3A, this is to the renal vein and it is segmental branch. Or invade the bilfocalicea system or invade a perirenal and or renal sinus fat, but not beyond the growth. So this is the 3A. The 3B extend into the vena cava below the diaphragm. 3B extend to vena cava below the diaphragm. 3C extend into vena cava above the diaphragm or invade the wall of the vena cava. So this is the 3A. The 3A, the tumor is in size, but actually the 3A, as I mentioned, into this is, if we make it clear here, tumor 3A stage 3A, the tumor into the renal vein, okay? The tumor extends into renal vein or segmental branch, invade the bilfocalicea system, or invade the perirenal fat, but not beyond the garrota. This is 3A. Okay, this is a 3A. It might be any size, but with this characteristic. Okay. When we come to 3B and 3C, we will see if the tumor is 3, A or 3C. The tumor is B or C. B, that's the tumor. It's extend into the IVC, as you see here. Extend to IVC below the diaphragm. It must be below the diaphragm. But T3C, the tumor extend into the vena cava above the diaphragm. As you see, this is the diaphragm. Above the diaphragm, this is the T3C. I hope this is clear. Okay, very important to differentiate between T3A, T3B, and T3C. T3A, the tumor extends into the renal vein. As you see, the tumor reaches the renal vein and segmental renal vein, or it is segmental branch, or invade the bilfocalicea. This is the bilfocalicea system, or invade the perirenal or renal sinus, but not beyond the garrota. This is the garrota fascia, not beyond it. Therefore, it is stage T3A. T3B, the tumor invade, extend into the vena cava below the diaphragm. This is the diaphragm, below the diaphragm. And also T3C, the tumor extend into the vena cava above the diaphragm. This is diaphragm. Above the diaphragm, this 3C. Also, regard the lymph nodes, no regional lymph nodes identified or shown, as well as in C3, T3, A and B and C, no distant metastasis. Let's take 3 renal cell carcinoma. Here, it's continuation, no regional lymph nodes, BT1, 2, 3, no. The size, it is as any size with the previous characteristic. The T4, the tumor invade beyond the garrota fascia, including contiguous extension into the ipsilateral. This is very important point for T4. It invade the ipsilateral adrenal gland. The tumor invade beyond the garrota fascia, including the contiguous extension into the ipsilateral adrenal gland. This is the T4, as you see here, and the ipsilateral adrenal gland is included. T4, the tumor beyond the fibrous layers that surround the kidney garrota and extended into adjacent organs. In 0, in X, no regional lymph nodes, in 0, no sign or spread. There might be metastasis. Distant metastasis is this is known as M1, but not with T4. So T4, it is in 0, N0, and M0. The distant metastases include lymph nodes, or also most common for the kidney cancer metastasis to the lung, bone, liver, brain. Regional lymph nodes, it is in X, regional lymph node cannot be assessed. In 0, no regional lymph nodes, metastasis. In 1, that's the metastasis to the regional lymph nodes. The distant metastasis is M, M0, no distant metastasis. M1, distant metastasis cannot be, the distant metastasis is present. MX is that the distant metastasis cannot be assessed. Regional lymph nodes include renal hilar, aortic, intra-aortic cable, and cable. Very important. The right, it is passed to the intra-aortic cable. The left, it's go to the para-aortic cable, para-aortic lymph nodes. The left RCC to the para-aortic, the right one pass to the, or metastasis to the inter-aortic cable. So this is the most common: renal hilar, aortic, inter-aortic cable, and cable. Treatment of localized non-metastasis RCC. Have general information here. Surgical excision is the most effective therapy to treating RCC. Excision of the renal mass may not necessary in the following situation. If small angiomyolipoma and Bosniak 1 and 2F, or renal cyst, metastasis to the kidney from lymphoma, there is systemic therapy for the specific type. Nephrectomy is seldom indicated for this type. The patient cannot tolerate surgical extirabations and unresectable tumor. This is a excision of the renal mass, not necessary for those group. If it's small renal mass, that will undergo active surveillance. If some angiomyolipoma types, Bosniak's category 1 and 2, 2F, renal cyst, metastasis of the kidney, example lymphoma, systemic therapy, and patient cannot tolerate surgical extirpation or unresectable tumor. Radical nephrectomy is the gold standard for treating RCC. Nephrospastic surgery procedure is recommended in the following patients. If the renal mass less than 7 centimeters, that are amenable to nephrospering cell. So the renal mass less than 7 centimeters, this is better to do nephrospering surgery. So nephrospering surgery indicate in this group. The another indication of nephrospering surgery, there is an imperative indication for renal sparing. The minimal invasive laparoscopic or robotic technique is preferred for excision of the renal mass when it does not compromise oncological control. The surveillance of enhancing renal mass in the absence of metastasis. The surveillance, the 2021 AUA guideline states that the active surveillance is an option for pathology lesion is uncertain. That the tumor, for example, the tumor less than 2 centimeters. Oncological risks are particularly low, or initial management of the patient with a clinical state T1. The renal mass is less than 2 centimeters, or in patient with clinical state T1, mass is a significant completing risk of death or morbidity from intervention. So it is better to do for them surveillance. The risk of malignancy high, grade tumor or local spread beyond the kidney, and metastasis rise as the primary tumor increases is also considered for surveillance. A follow-up testing should include renal imaging, chest X-ray, and laboratory annually as the clinical indication, blood urea, nitrogen, creatinine, and estimated GFR, liver function test, lactate dehydrogenase, alkaline phosphatase, serum calcium, CBC, urine analysis. This is a laboratory. Chest imaging, this is annual and also as clinically indicated. Renal imaging with ultrasound, CT, MRI, at least annually for them to do such image. This is a AUA for surveillance for small tumor or less than 2 centimeters. Oncological risk particularly low, if the patient have oncological risk particularly low, or if initial management of the patient with T1, it is better to do surveillance for them. Or the patient with a risk of malignancy, high-grade tumor, locally spread beyond the kidney, and metastasis rise as the primary tumor increase. So tumors that rise, hereditary leiomyoma, RCC, tumor arise from succinate dehydrogenase deficiency, and RCC behave aggressively even when they are small. The tumor associated with the syndrome should not be managed by surveillance. This is the general. The risk of surveillance is lowest when the renal tumor mass is less than 3 centimeters. When enhancing renal mass less than 3 centimeters are initially discovered, 20% are benign, 13% are high grade, 6% extended locally outside the kidney, BT3, and less than 4% have a nodal or distant metastasis. The risk of malignancy and high-grade tumors and locally spread beyond the kidney and metastasis rise as the size of the primary tumor increase So this is the risk of malignancy. If high-grade locally spread beyond the kidney and the metastasis rise the size of the primary tumor, therefore increase the primary tumor increase. In untreated patients with enhancing renal mass less than 3 centimeters in greater dimension, the risk developing metastasis within 2 to 3 years of diagnosis is 1%. So 1%, this is the risk of developing metastasis with 2 to 3% for patients with renal mass less than 3 centimeters. So therefore, the risk of developing metastasis in those groups within 2 years or 2 to 3 years, it is 1% only. This is the tumor less than 3 centimeters in size, greater dimension. The light tumor have a high risk of developing metastasis. More than 3 or light tumor have a high risk of developing metastasis. This is a risk, as we mentioned, the risk of primary. This is a primary risk. The primary RCC size is if less than or equals 3 centimeters, as we mentioned, the risk of metastasis at the presentation is 4%. This is at the presentation. But according to this here, it is if less than 3 centimeters, the greater dimension, the risk within 2 to 3 years is only 1%. So the risk of high-grade tumor in those group, this is actually 13%. This is high grade, it is 13%. If more than 3 or equal 4, it is the time of the presentation risk of metastasis is 7%. Compared with high group, it is 16%. This is in more than 3 or equal 4. In more than 4 to 7, it is 16%. This 16% come here, and it is actually high grade. It is the risk of high grade 21%. 7 to 10, it is 13% at the presentation, and 27% as high grade risk of high grade tumor. 10 to 15, this is 41%, and it is to 33%, this is for high grade. If the size is more than 15, the risk of metastasis is 51%, and the risk for a high-grade tumor for those size or those patients, it is 38%. Among patients undergoing surveillance for small renal masses, the mean tumor growth rate is approximately 0.3 centimeter, 0.03 centimeter. 0.3 centimeter per year. The tumor growth rate does not relay the distinction between the benign and malignant lesions. However, metastases appear to be more likely in patients whose primary tumor demonstrate interval growth. So, among the patients undergo surveillance for small renal mass, the mean tumor growth rate is approximately the mean renal tumor growth rate is 0.3 centimeter per year. Okay, this is for surveillance. The tumor growth does not relay distinction between the benign and malignancy. Surveillance for renal mass less than or equal 4 has a low risk of metastasis and local tumor growth in the short term. However, in the long term, surveillance of these masses may compromise survival. In a retrospective study patient with enhancing renal mass less than or equal 4, Zenith 2009 compare about 9,858 patients who underwent partial and radical nephrectomy to 433 patients who underwent non-surgical management, no excision, no ablation. So this study, excision improved cancer specific survival by much as 9.4% at 5 years survival. So the excision, this compares surveillance with excision, this study. Compare those patients underwent partial radical nephrectomy and the patient underwent non-surgical management, that's surveillance, no excision, no ablation. So excision improved cancer-specific survival by about 10% in 5 years. So 9 to 4% of the patient, 9 to 4% of the patients have a 5-year survival. Recommended baseline testing before surveillance is begun. The following tests are recommended to obtain accurate baseline assessment of primary tumor and to check assessment. We recommend to do abdominal cross-sectional imaging, CT or MRI, with and without intravenous contrast if there is no contraindication to contrast. And also, we also advise to do chest X-ray, chest imaging X-ray or CT, and lab investigation, as we mentioned previously, blood urea, creatinine, estimated ESR, LFT, LDH, and ALB, and serum calcium, complete blood count, urine analysis. Additional metastatic evaluation should be done when symptom laboratory test or other imaging suggest metastatic disease. Optional baseline testing renal mass biopsy is optional if the patient's medical condition would preclude treatment of the mass. Then renal biopsy is indicated. So we indicate renal biopsy if the baseline testing renal mass biopsy is if the patient medical condition would preclude treatment of the mass. If the patient can tolerate the treatment and would consider treatment based on biopsy results, then the biopsy of the mass is reasonable. The intensity follow-up can modify the base of on the tumor histology. Assessment of the growth of the renal mass. We will assess the size of the mass on ultrasound, appear to correlate well with the size of the mass with CT or MRI. So mass on MRI so have a very important correlation. So appear to correlate well with the size of the mass on CT and MRI. Therefore, after the mass has been well characterized with baseline CT or MRI, ultrasound may be used to determine for change in the tumor size. Therefore, after the mass has been well characterized with baseline CT and MRI ultrasound may be monitor the change in the size. An ultrasound finding of concern, the CT MRI can be obtained and compared to the baseline imaging to confirm the tumor growth. Data suggests that the inter-observer and integrated observer variability is less than 3.1 millimeter when measuring the tumor size. This is the data suggests that the inter-observer and intra-observer variability is about less than 3.1 millimeter. Therefore, variation of less than 3 millimeters in the tumor size should not interpreted as tumor growth unless there is persistent increase in size over 2 image studies. So if we have 2 image study increase less than 3 millimeter, we can consider this increase in the tumor size. But it's the usual variability, intra-observer variability, when the measuring of the tumor size is less than 3.1 millimeter. Example follow-up protocols: if patient elect undergo surveillance, the first follow-up image should be conducted within 3 to 6 months after initial diagnosis. If it is even if the biopsy is benign, we will do surveillance for 3 to 6 months surveillance. The first follow-up imaging, this must be 3 to 6 months with CT or MRI. Okay, should be consist of the abdominal cross-sectional imaging, CT or MRI, with contrast if the patient have no contraindication. 3 to 6 months imaging is compared to the baseline imaging to determine the growth. Thereafter, follow-up testing should include renal imaging with ultrasound, CT, MRI. Imaging should be done, this is at least annually, and imaging should be done even if the biopsy benign tumor, because benign tumor can grow over the time and threatens the kidney function. Chest imaging annually, a chest imaging that includes chest X-ray or ECG, as clinically indicated, chest X-ray is recommended in patients who had no renal mass biopsy or who as a biopsy is non-diagnostic, oncocytoma or the tumor with oncocytic fissures or renal cell carcinoma. All these must do annual chest imaging with chest X-ray. Okay, so the chest X-ray indicated is recommended in patients who had no renal mass biopsy, or those who have biopsy is not diagnostic, or those who have oncocytoma, or those who have a tumor with oncocytic fissure, or those who have renal cell carcinoma. Also, oncocytoma is considered benign. Oncocytoma can coexist with RCC, and it can be difficult to distinguish between oncocytoma from oncocytic cancer. If the patient's oncocytoma are follow as they have RCC. Laboratory tests also must be done annually as clinical indicated. The treatment of the initial renal mass consider when any of the following criteria is present. If the patient have mass demonstrate ongoing interval, this is the mass grows larger than 3 centimeters in greater dimension, or the mass demonstrate ongoing interval growth, or that especially more than 0.5 centimeter per year. This is considered very important. And the tumor developed an infiltrative appearance on imaging, or the clinical stage increase, or the patient develops symptom attributable to the renal mass, or the biopsy show RCC with aggressive features. During surveillance, symptom may be developed, metastasis may be developed, the tumor may grow, and possibly eliminating the options of nephro-sparing surgery for this patient. The cure rate of subsequent treatment may decline. So that this is during surveillance, all this kind of care. There is conflicting data about whether surveillance compromise cancer-specific survival compared to treatment. However, close surveillance follow-up by delay intervention appear to have acceptable oncological outcome for stage T1 renal tumor. The treatment for renal mass should be considered when any of the following criteria present. If the mass grow larger than 3 cm in greater dimension, we must do treatment for this patient. If the mass demonstrates ongoing interval growth, and if the mass infiltrative appearance on imaging, and also if the clinical stage increase, and if the patient develops symptom attributed to the renal mass, or if the biopsy show renal cell carcinoma with aggressive feature. What is the management? The management surgical radical nephrectomy. A radical nephrectomy is removal of the growth. This is a very important point for radical nephrectomy. Growth fascia and it is contain kidney and perirenal fats, the tumor thrombus. All this should be removed. Often it might be open or laparoscopic radical nephrectomy. Achieve equivalent cancer control, both. Achieve equivalent survival rate. Achieve equivalent quality of life, but the laparoscopic radical nephrectomy result in less intraoperative blood loss, less postoperative pain, and short hospital stay. Very important this. The radical nephrectomy is best utilized in the patients who need or meet all the following criteria. So we'll do radical nephrectomy if the patient meets the following. Partial nephrectomy would place the patient at high risk of positive surgical margin or would not preserve sufficient viable normal kidney to make the risk of the partial nephrectomy worthwhile. No imperative indication for renal sparing. No preoperative renal insufficiency. Example, the glomerular filtration rate more than 60. If less than 40 or 35, this is indication. And also no preoperative proteinuria, normal contralateral kidney. Unexpected postoperative GFR more than 45. As I mentioned, expected postoperative GFR must be not less than 45. Okay, so this patient is suitable for radical nephrectomy. It is best utilized in this patient. Partial nephrectomy places the patient at high risk of positive surgical margin. Or partial nephrectomy places the patient that not preserve sufficient viable normal kidney to make the risk of partial nephrectomy worthwhile, and no imperative indication for renal sparing, and no preoperative renal insufficiency. Okay, a normal contralateral kidney and expected postoperative glomerular filtration rate more than 45 ml per minute. Partial nephrectomy is usually preferred for clinical stage T. So partial nephrectomy is usually preferred for clinical stage T1. The tumor size less than 7 cm is greater dimension confined to the kidney. Radical nephrectomy is usually utilized for the tumor more than T2 tumor. So the T2 tumor, more, this is the best to do radical nephrectomy. But the T1 less than 7 cm, it is better to do nephrospairing surgery. The surgical procedure to remove all the kidney. This is the radical nephrectomy with the Grota fascia. And also, as I mentioned, we will remove the Grota fascia and tumor thrombus. All this must be removed. Renal sparing surgery, nephrospairing surgery treatment. Radical nephrectomy remove the entire kidney, including normal, abnormal tissue. We speak about all this previously, where the renal sparing surgery attempted to spare much of the normal epilateral kidney as possible. Nephrospairing surgery treatment result in less reduction of the glomerular filtration rate compared to the radical nephrectomy. Imperative indication of renal sparing surgery. The renal sparing surgery treatment indicated regardless of the tumor characteristics when the preservation of the renal function is crucial. Imperative indication include tumor size is solitary, poor contralateral renal function, bilateral renal tumors, and poor overall renal function. Contracted kidney is threatened by disease that might worsen renal function. Example, diabetes or hypertension. Contracted kidney is threatened by disease that's run in family like von Hippel-Lindau or tuberous sclerosis that cause renal tumor. Okay, these two most important genetic disorder associated with RCC. Contracted kidney must be aware to do partial nephrectomy. Contracted kidney and contracted kidney seized by disease that can result in renal tumor, or seized by disease that worse the renal function, like diabetes, hypertension, or poor overall renal function, or bilateral renal tumors present, and also poor contralateral renal function, tumor is solitary. The feasibility of sparing depends on the tumor size, location, and within kidney. So this is the tumor size and its location within the kidney is very important. Peripheral tumor less than 7 centimeters, so it's very important indication for nephrospastic surgery. Are more amenable to nephrospastic surgery, where the renal sparing would compromise complete excision of the malignancy or would not preserve sufficient normal function to make the risk worthwhile, then the radical nephrectomy is preferred. Renal sparing can be performed in situ or extracorporeal nephrectomy with bench surgery. So we have bench surgery and autotransplantation. In situ surgery is preferred. This is the renal sparing surgery can be performed in situ or extracorporeal. So in situ, this is preferred. Renal sparing surgery can be achieved by partial nephrectomy or by thermal ablation. So this is the renal sparing surgery. You can do it by both partial nephrectomy, laparoscopic or open, or by thermal ablation. Partial nephrectomy is excision of the tumor margin of normal tissue. Partial nephrectomy is preferred method of nephrospastic surgery because abundance of long-term data confirm its efficiency. So also it is most population-based analysis show that the cancer-specific mortality is lower after partial nephrectomy than other ablation. Thermal ablation use cold or heat destroy the tumor in situ without excision. We use cold or heat to destroy the tumor in situ without excision. Thermal ablation appear to result less decline in GFR. So less decline in GFR than partial nephrectomy, but the ablation have high local recurrence rate than partial or radical nephrectomy. Furthermore, retrospective data suggests that ablation results in a two-fold higher risk of dying from the kidney cancer compared to the partial nephrectomy. Removal of renal tissue may decrease the glomerular filtration rate, GFR. Lower GFR after renal surgery corresponds to a high risk of cardiovascular event, a high risk of dying from the cardiac events, and lower overall survival, especially when the GFR is less than 60 ml per minute. This is the removal of renal tissue may decrease the following the glomerular filtration rate by this method. The given about finding preserving as much renal function as possible, this helps reduce the risk from this. This is a partial nephrectomy by open methods. This is how we do nephrectomy. The procedure placed under general anesthesia and may be open laparoscopic or robotic procedures. Open nephrectomy access the kidney through the incision into the skins. And the laparoscopic procedures is several small cuts are made into the skin abdomen, which is inserted the camera instrument used by surgeons and his assistants. And robotic assisted laparoscopic nephrectomy instrument control affected through the machine connected console, which Dr. removed overtly. Time spent the following nephrectomy can vary depending on the procedure technique, open, laparoscopic, or assist. So how nephrectomy performance is performed under anesthesia, and all this is mentioned previously. And after the procedure, discharge receives the instruction assuming any anticoagulant. This is after the anesthesia. And medication must be taken like aspirin and so. How long to avoid physical exercise and strenuous is very important. Antibiotic medication to take at home, saving hospitals. result and evaluation. This is as post-operative. Very important to remember for your patient to restrict animal protein and salt, diet rich in fruit and vegetable and low fats. It must be instructed. For those who have hypertension, must maintain their blood pressures, daily exercise, maintaining body weight with normal range. This is must be done. Thermal ablation. Thermal ablation, we speak about it. This is the destructive without excisions, which usually accomplished by freezing uh, um, cryoablation or heating radiofrequency ablation. Also, no randomized trial compared cryoablation and radiofrequency ablation, respectively, data show that they have similar oncological efficiency and similar complication rate. So, cryoablation, the tumor is cooled to 20 to minus 40 centigrades. That temperature induce cell necrosis. So here, this is the cryoablation nephros-bearing surgery. Two freeze thaw cycles improve the cell kill. A common regimen is 10 minutes to freezing, then 8 minutes of thinnings, another 10 minutes of freezing, then 10, 8, and 10 protocol. So it is 10, 8, 10 protocol. It is known as two freeze thaw cycle. This improves cell cycle, and it is cryoablation by centigrade. It is 20 to 40 minus 40 centigrade, minus 20 to minus 40. Freezing is monitored by ultrasound. The necrosis zone is smaller than the frozen regions revealed by ultrasound. In order to account for this, the hyperechoic edge of the ice ball on the ultrasound must extend beyond the edge of the tumor by at least 5 millimeters. Radiofrequency ablation, this is another way of the thermal ablations. The tumor is heated to between 50 to 105. This temperature induces cell necrosis. So the radiofrequency ablation by 50 to 105 centigrade. The temperature induced thermal necrosis. Probe deliver high frequency alternating current into the tumor. The 460 to 500 kHz. This is current create an electromagnetic field that agitates the molecules next to the probe. This agitation creates friction between the molecule that heats the surrounding tissue. The source of the heat is not the probe. The heat arises from the agitated molecule around the probe. Ablation can be monitored using ultrasound, CT, or MRI. Ablation can be accomplished through the open laparoscopic or percutaneous approach in most cases. As a percutaneous approach is preferred because it minimizes morbidity. Biopsy of renal mass is recommended before proceeding with tumor ablation. Thermal ablation is generally referred to for non-cystic clinical stage T1 tumor that are less than 3 centimeters because the risk of complications such as tumor fracture and bleeding are higher when the tumor size is more than 3 centimeters. The rate of recurrence is higher when the tumor more than 3 centimeters. The disease survival free rate is lower when the tumor is more than 3 centimeters. Thermal ablation has not been well studied in cystic masses. The tumor that are intrarenal, close to the renal hilum, are close to the renal sinus, or close to renal sinus are more difficult to do thermoablation. To treat with thermoablation, the peripheral exophytics tumor are easier to ablate. So the peripheral is preferred. When structure adjacent to the kidney are too close to allow for safe ablation of the tumors, the clinician can move this nearby structure away from the expected ablation zone to prevent safe tumor ablation using the methods such as percutaneous hydrodissection or spacer balloons. What is the complication? The complication include hematoma, pain, and infection. Pneumothorax can occur when ablating upper pool renal masses. Rare serious complication includes bleeding, require transfusion, persisting urinic extravasation, incomplete loss of epistatic renal function, injury to the nearby organs such as ureter or bowel, tumor seeding along the prop tract. Thermal ablation appears to result in less decline in the GFR than partial nephrectomy. So less decline in GFR than partial nephrectomy. Local recurrence is more common after single ablation, the local 6%. Than partial nephrectomy is 3% or radical nephrectomy 1%. So 6-3-1. 6-3-1, remember 6 for thermal ablation, 3 for nephrosparing surgery, 1 for radical, 3 for partial nephrectomy, surgical, and 1 for radical nephrectomy. This is the recurrence. However, persistent tumor and local recurrence can be treated with repeat ablation. When repeat ablation are included, the risk of local recurrence similar between ablation and partial nephrectomy. So when we repeat it again, the recurrence rate becomes 3% for thermal ablation. Salvage excision of the tumor may be more difficult after ablation. Retrospective data suggests that ablation results in twofold higher risk of dying from the kidney cancer compared to the partial nephrectomy. So this is ablation increased twofold risk of dying compared with partial nephrectomy. The EUA 2021 guidelines state that ablation should be offered to frail and or comorbid patients with small renal masses and inform the patient about high risk of local recurrence and or tumor progression. EUA 21 guideline states that the physician should consider thermal ablation alternate approach for management of the T1A solid renal mass less than 30 centimeters in size. And the patient's counseling should include increased likelihood tumor persistence or local recurrence relative to the surgical exit. The residual tumor after ablation and local recurrence, this is defined as any of the following. Imaging shows tumor in the same area of period treatment that enhance with contrast more than 3 to 6 months after ablation enlarge over time or fail to regress over time. Or image show new satellite tumor immediately surrounding the treated area. Or biopsy showed tumor in the same area of period treatment, or tumor detected along the track where the probe was placed. The renal biopsy for residual tumor or local recurrence, if there is suspicions of the residual cancer or local recurrence on the imaging, then the renal mass biopsy should be performed. The biopsy should sample the enhanced area of the tumor. Biopsy of non-enhancing area are likely show fibrosis, especially the cancer, the center of the mass, where the ablation is typically initiated. For renal mass that have undergone successful ablations, immediate post-ablation imaging show a slight enlargement of the tumors and may show rim enhancement over the next few months. The tumor shrink and no longer enhance. Also with radiofrequency ablation and the tumor shrinking may be minimal. Patient with no biopsy or patient whose biopsy is non-diagnostic or oncocytoma or the tumor with oncocytic feature should be probably followed by with assumption that the tumor's renal cell carcinoma oncocytoma can coexist with RCCs. It can be difficult to distinguish between oncocytoma from oncocytic feature. So those patients must do biopsy. Example, follow-up protocols. If patient elect to undergo thermal ablations, The first follow-up imaging should be 3 to 6 months after ablation and should consist of CT, cross-section CT and MRI, and without intravenous contrast unless contrast is contraindications. 3 to 6 months can determine the treatment success. Thereafter, follow-up testing should include the patient's source pre-ablation renal mass biopsy show benign tumors that is not oncocytoma, and if 3 to 6 months it can show treatment success, there is no ongoing treatment related to complications, then the further abdominal imaging test is not necessary. So for patient did not have a renal mass biopsy or who biopsy show RCC, oncocytoma, tumor with oncocytic feature, or non-diagnostic finding, use the follow-up protocol described below. We will do renal imaging, ultrasound, CT annually, 5 years survey, and clinically indicated. Renal imaging may be performed more often using more detailed scan and chest X-ray or chest imaging annually, CT or X-ray, for 5 years as clinically indicated. Chest imaging after 5 years can be considered based on patient risk. Laboratory test also annually. So imaging annually for 5 years, renal imaging annually, CT, MRI, ultrasound, chest X-ray annually, and laboratory annually, all this for 5 years. Partial nephrectomy removes the tumor with margin of normal renal tissue. This method removes the tumor can be classified into the incision or inoculation. As the incision, the normal kidney around the tumor is incised, so the tumor can be removed with a modest macroscopic margin of normal kidney. Inoculation, the tumor is removed by blunt dissection between the tumor pseudocapsule and the normal kidney. This is different between two-part incisional or inoculation. Partial nephrectomy for stage T1 tumor when complete tumor excision or excision can be achieved. Partial nephrectomy is a treatment of choice for T1 tumor less than 7 cm greater dimension. Partial nephrectomy results lower risk of chronic renal insufficiency than radical nephrectomy. Partial nephrectomy and radical nephrectomy have equivalent oncological efficiency in T1. Cancer-specific mortality is lower with partial nephrectomy than with ablation therapy. Partial nephrectomy for T2, partial nephrectomy is an option for stage T2 tumor when the partial nephrectomy completely excises the cancer and will preserve a sufficient amount of normal kidney to make the risk worthwhile if the tumor less than 7 cm. In this case, partial nephrectomy result high blood loss and high risk of complications than radical nephrectomy. Stage 3, T3 and T4 radical nephrectomy is generally performed for those stages of primary cancer unless there is an imperative indications for renal preservations. Surgical margins is historically of a 1 centimeter margin of normal tissue was recommended. However, the size of negative surgical margin does not impact prognosis. A close margin achieves the same cure rate as an ample margin. Therefore, a close margin should be considered as truly negative. Positive surgical margin occur in approximately 3% of the patient undergo partial nephrectomy. With short-term follow-up, less than 3.5 years, a positive margin does not appear to alert cancer-specific or overall survival. Patients with positive margin have higher risk of local recurrence. However, most patients will remain disease-free. In fact, when epilateral radical nephrectomy is performed for positive margin after partial nephrectomy, residual tumor is found in less than 16% of the time. When the positive margin is found, but there is no growth or residual tumor, surveillance is usually appropriate. Okay, because most of these patients will remain disease-free. However, a radical nephrectomy or repeat partial nephrectomy may be considered in patients with particularly aggressive tumor, sarcomatoid or high-grade or collecting duct tumor. That's why, because this patient may have high risk of for lethal recurrence. When there is gross residual tumor remaining after partial nephrectomy, consider performing either radical nephrectomy or repeat partial nephrectomy to remove the residual tumor. Ablation may be used in select case. Renal ischemia time. This is defined as the duration of the time that part of all the kidney is without arterial blood flow because of vascular clamping. So the most important for us is in this definition of renal ischemia is arterial, because we clamp this artery, so therefore is known as renal ischemia time, because the duration of the time that's the part or all of the kidney is without arterial blood flow. Clamping of renal blood flow is done to minimize bleeding while excising the tumor. Irreversible renal damage is thought to be occur after 20 to 30 minutes. That's irreversible. So it must not more than 20 minutes. Of the irreversible occur after 20 to 30 minutes of warm ischemia time and after about 90 minutes of cold ischemia time. Okay, so warm ischemia time is 20 to 30 and cold ischemia time is 90 to 90 minutes. Minimize ischemia renal damage during partial nephrectomy. Avoid hypotension and hypovolemia. Traditionally, the patient receive mannitol 12.5 milligram via administered at 5 minutes and 10 minutes prior to clamping the renal artery. Mannitol reduce ischemic injury by scavenging free radicals and by reducing oxidative cellular damage. The respective study suggests no benefit of using mannitol. In addition, recent randomized trial by Savarov 2018 in patients with pre-operative GFR more than 45 showed using single dose of 12.5 dose of mannitol during partial nephrectomy did not improve post-operative GFR compared to placebo. However, this trial did not examine whether the mannitol is beneficial when using the regimens of 12.5 milligram dose or when using for patients with preoperative GFR less than 45. Clamp renal artery only, avoid unclamping and reclamping. So clamp once, okay, not clamp but reclamp. It is leaving the renal vein. Unclamping may permit retrograde renal perfusion. However, it may result in more bleeding. Rather than clamping the main artery, clamp only segment of the artery, then free the origin of the tumor. Minimize the renal ischemia time when the kidney is not cooled, then warm ischemia time should be less than 20 minutes. If warm ischemia time is expected to be longer than 20 minutes, then the traditional approach has been to cool the kidney after clamping the artery, surround the kidney with ice bath for 15 minutes, and cool the kidney for 50 centigrade. They use what we call it this traditional approach. Okay, cooling the kidney after clamping the artery, surround the kidney with ice bath for 15 minutes and cool the kidney for 15 degrees, so 15 of 15 centigrade. Recool the kidney at least every 30 minutes. However, a recent randomized study Pro, that's 2021, show that the renal hypothermia offer no benefit for preservation of the renal function test when clamping time is less than 60 minutes. Also, few patients the study had GFR less than 45. The study was able to show that hypothermia did not benefit this patient. When the renal hypothermia is utilized, cold ischemia time should be less than 60 minutes. If you use hypothermia, it is better to use it less than 60 minutes. But the kidney can be completely recovered after 60 to 9 minutes of cold ischemia. Laparoscopic versus open partial nephrectomy. Open and laparoscopic partial nephrectomy achieve equally effective cancer control and survival. Warm ischemia time is usually longer with laparoscopic partial nephrectomy. Compared to open partial nephrectomy, laparoscopic partial nephrectomy lower intraoperative blood loss and high risk of postoperative hemorrhage. Open and laparoscopic have a similar transfusion rates. Patients undergo laparoscopic partial nephrectomy have higher risk of being converted to the radical nephrectomy. This is the laparoscopic. Than patients undergo open partial nephrectomy. The rate is 22.1% to 0.05%. Laparoscopic partial nephrectomy has high rate of re-operation for complication than open partial nephrectomy, 3.4 versus 1.6%. This is radical nephrectomy versus partial nephrectomy. Radical partial nephrectomy high rate of perioperative complication compared to the radical nephrectomy. Partial nephrectomy have a lower risk of chronic renal insufficiency than radical nephrectomy. Partial nephrectomy achieve equivalent or possibility better overall survival compared to radical nephrectomy. There's a potential overall survival benefit for partial nephrectomy arise from reduction in non-RCC related deaths, perhaps by preventing renal insufficiency. The rate of positive surgical is higher with partial nephrectomy than with radical nephrectomy, 2 to 3% versus 1%. This is a positive surgical margin. And partial nephrectomy is a slightly higher local recurrence than radical nephrectomy. Is 3% and here is 1% compared with thermal ablation which is 6%. Partial nephrectomy achieve equivalent cancer-specific survival compared to the radical nephrectomy. Radical nephrectomy versus partial nephrectomy in details. This is a erotic study about 30,000 of prospective randomized trial compare the partial nephrectomy and open the patient normal contracted kidney and RCC was solitary and less than 5 cm in diameter. For partial nephrectomy, macroscopic margin of renal tissue was removed, inoculation was not performed. Complication of necrotics show that the partial nephrectomy has higher rate of complication compared to the radical nephrectomy. The following complications were likely with partial nephrectomy: hemorrhage within more than 1 liter of blood, 3 to 1.1% versus 1.2% for radical. Urine leak fistula 4.4 to 0 with radical nephrectomy. Reoperation for complication 4.4 as well as fistula and urine leak versus 2.4 for radical nephrectomy. Renal function. Partial nephrectomy result in lower risk of chronic renal insufficiency than radical nephrectomy. Retrospective and randomized controlled data show that the patient undergo radical nephrectomy have high risk of developing postoperative glomerular filtration rate less than 60 milli per minute. However, it's appeared that the risk of severe renal dysfunction, glomerular filtration rate less than 30, is similar after partial and radical nephrectomy. Retrospective study that suggests that the partial nephrectomy is less likely to cause proteinuria compared to the radical nephrectomy. Oncological efficiency survival, the rate of positive surgical margin is higher with partial nephrectomy than radical nephrectomy, which is actually 2 to 3% versus 1% for radical nephrectomy. A randomized and retrospective study show that the partial nephrectomy and radical nephrectomy achieve equivalent cancer-specific survival in patients with stage T1 cancer, but the local recurrence is higher with partial nephrectomy, as I mentioned previously, 3% for partial and 1% for radical. Also, the data are conflicting. Some retrospective studies suggest that the patient undergo partial nephrectomy for clinical stage T1 RCC have longer overall survival than the patient undergo radical nephrectomy. Improve overall survival in patient undergoing partial nephrectomy occur mainly by reducing non-RCC related death, since the lower GFR correlate with the lower overall survival. Partial nephrectomy may achieve its overall survival benefit by preventing a decline in GFR. Erotico, after median follow-up for 9.3 years, the study was unable to demonstrate equivalent cancer control for partial radical nephrectomy. It was also unable to confirm the retrospective finding that partial nephrectomy achieve higher overall survival. The inability to show the advantage of partial nephrectomy probably is because poor accurate forced the study to close prematurely. Less than 50% of the required patients were enrolled. Therefore, the data was underpowered to adequately assess survival endpoint. The author that the oncological equivalent for nephrospastic surgery and radical nephrectomy could not definitely show in this randomized study, but nowadays generally accepted, and EORTC support recommendation to use nephrospastic surgery in small tumor at the first line procedures whenever technically feasible. Erectile dysfunction retrospective that suggests that the radical nephrectomy lead to high rate of postoperative erectile dysfunction than partial nephrectomy. One possible explanation for this is the renal insufficiency from radical nephrectomy produce endothelial cell dysfunction and increase rate of erectile dysfunction. Adrenalectomy during nephrectomy. Epislateral adrenalectomy is recommended when the suspicions of the direct invasion or metastasis of the adrenal gland based on the preoperative imaging or based intraoperative finding. Adrenalectomy may also be considered when there is a large upper pool tumors other than the epislateral adrenal gland can be spread. Routine removal of epislateral adrenal gland during nephrectomy does not improve the survival. Direct invasion of metastasis to the adrenal gland is uncommon. If unilateral adrenalectomy is performed, adrenal insufficiency rare because the patient have normal contralateral one. For patient undergo cytoreductive nephrectomy for metastasis, RCC, or indicate of adrenal sparing are same for patients with non-metastatic RCC. The regional lymph nodes dissection, clinical stage and 0 patients with preoperative imaging and intraoperative findings show no lymph nodes or lymphadenopathy, then perform a regional lymph node dissection is option. EORTC was a prospective randomized trial compare radical lymph node to the radical nephrectomy to the radical nephrectomy with lymph nodes in patients with clinical stage T1 to T3 and 0 M0 RCC. With the median follow-up 12.6 years, there is no difference in overall survival. The disease-specific survival local progression, so there is no difference. Thus, regional lymph node dissection does not improve survival in patients who undergo radical nephrectomy with T1 to T3 with no lymph nodes, RCC. Lymph node dissections does not increase the risk of survival, does not increase risk of surgical complication. Regional lymph node metastases were found 1% of palpably normal nodes, 17% of palpably large nodes. This is why lymph node dissection is recommended when there is a palpable node are discovered intraoperatively. So, some urologists advocate lymph node dissection for patients with high risk of node metastasis. The risk of node metastasis can be predicted preoperatively using nomogram, or intraoperatively using frozen section. High risk for more than or equal to risk factor, stage 3 to 4, grade 3 to 4, and tumor size more than or equal 10 centimeter, tumor necrosis, or sarcomatoid element. All this, it is better to do intraoperative frozen section or normogram preoperatively. Okay, so this is very important for assessing the lymph nodes involvement and lymph node dissection. Clinical stage in patients, preoperative imaging or intraoperative finding show lymphadenopathy. Lymph node dissection does not improve survival in patients with clinical stage N1. However, regular lymph node dissection includes removal of abnormal lymph nodes is recommended in N1 patients because it's helped to accurately stage the tumor and semi-line lymph node does not harbor the malignancy. The most common location of node metastasis is interaortocaval. This is for right side tumor and para-aortic for left side tumor, as I mentioned previously. Interaortocaval metastasis can be present in the absence of hilar metastasis. So interaortocaval in hilar metastasis, it can be present, can be absent. If there is hilar metastasis, you cannot find interaortocaval. You might not find interaortocaval lymph nodes. So the right side, it go to interaortocaval, and the left side, which go to the para-aortic lymph node. Corresponds to 2011 recommend the following lymph node templates. For the left side tumor, remove the para-aortic lymph nodes and interaortocaval for the from the crust of the diaphragm to the common iliac. So we use to do the para-aortic, interaortocaval, and the aortocaval from the crust of the diaphragm and the common iliac artery to the common iliac artery. We will remove all this for left side. For right side, what we will do, we will remove the paracaval, the interaortocaval lymph nodes from the crust of the diaphragm to the common iliac artery. Okay. Bilateral RCC, when possible, the renal sparing surgery is preferred for bilateral RCC. In the case where the bilateral renal RCC is necessary, the patient is placed on dialysis. Renal transplant may be an option if the patients remain cancer-free. When the planning radical nephrectomy on one side and nephron-sparing surgery on the other side, consider perform the nephron-sparing surgery first and delaying the radical nephrectomy until a late date. This helps avoid dialysis during recovery from the nephron-sparing surgery. The need for dialysis can be avoided if the contralateral kidney is still present to help sustain renal function. RCC with the tumor thrombus. RCC with the tumor thrombus, as general, RCC can grow into the lumen of the vein and that drain the kidney. The tumor within the venous lumen called tumor thrombus. The tumor thrombus typically remain attached to the continuous with the primary renal mass. We will continue later on. Here we have the RCC can grow, as I mentioned, into the extended. This is the tumor thrombus typically remain attached to the and continue with primary renal mass. The tumor thrombus grow tend to follow the direction of the venous flow. Therefore, the thrombus extend into the inferior vena cava will usually grow severely toward the heart. Once it's reach the heart, it will typically grow then to the right atrium rather than into the superior vena cava. So the various systemic including stage have proposed the design that the levels demonstrates commonly IVC. So the thrombus usually free floating in the venous lumens, but it can be invade into the vein wall. When the thrombus invade into the veins wall, then involve vein wall is excised. Synthetic graft may be used to constriction of the veins. The thrombus tumor invading the vena cava wall has a higher worse prognosis than free floating thrombus. In surgical candidate, tumor thrombus should be removed during nephrectomy because a longer term survival has shown achieved even when the thrombus extended into the right heart. Cardiopulmonary and venous bypass may be necessary to remove an extensive tumor thrombus, especially if extended above the diaphragm. Case reports show that systemic therapy can shrink tumor thrombus when thoracic incision or cardiopulmonary bypass poses an unnecessary risk. Systemic therapy may reduce the thrombus level enough to allow complete resection without a thoracic incision and without cardiopulmonary bypass. We speak previously about the adrenalectomy during nephrectomy. Bilateral adrenalectomy is recommended when there is suspicion of the direct invasions or metastasis to the adrenal gland based on the perioperative imaging or intraoperative finding. We speak about the bilateral previously. RCC with thrombus, we speak about it in details previously. You mentioned that RCC can grow to the lumen of the vein drain the kidney. The tumor thrombus typically remain attached to and continue with primary regional mass. Tumor thrombus follow the direction of the venous flow, can reach the heart, and various systemic has provided the designated level of the thrombus extends, commonly the level of the renal vein, IVC below the hepatic vein, IVC above the hepatic vein, IVC above the diaphragm into the right atrium, and the thrombus usually free floating in the venous lumen, but it can invade the vein wall. The thrombus invading the caval wall, it require have a worse prognosis and require reconstruction. Adjuvant therapy after nephrectomy. Many randomized studies of the adjuvant therapy have been conducted using agents such as radiation, interferon, interleukins, sunitinibs, sorafenib or sorafenib, exitinib, and barzolvolimab, and so far only study has shown benefit with adjuvant therapy is STARC trial. STARC trial patient with non-metastatic clear and cell RCC who were at high risk of recurrence after chemotherapy after nephrectomy were randomized to either sunitinib or placebo. High risk of recurrence was defined as the presence of any of the following: stage T4, regular lymph node metastasis, or combination of T3 and 0 or 4 months more than 2 or equal to, plus ECOG performance status more than 1. Sunitinib 50 mg per oral Q days was administered for 4 weeks. 4 weeks on 2 week off cycles for 1 year as tolerated, but was stopped sooner if the recurrence occurred within 1 year. Median disease-free survival was significantly longer. It's 1.2 years in sunitinib's group. So the dose is 50 milligram. We will use 4 week 2 on and 2 off cycle for 1 year as tolerable. But if there is recurrence, we can stop it. Data for overall survival not mature at the time of the report. Grade 3-4 adverse events were more common in the sunitinib groups. Based on this result, the FDA approved sunitinib for adjuvant treatment for patients with a high risk of recurrence following nephrectomy for RCC. The randomized ASSURE trial also studied adjuvant sunitinib in the patients with high risk of recurrence after nephrectomy for RCC, but ASSURE showed that no difference in the disease-free survival between adjuvant sunitinib and placebo. Given the conflicting data on the disease-free survival and the lack of proven overall survival benefits, many clinicians are not convinced that the sunitinib should be utilized for adjuvant therapy. In fact, the EUA 2021 guidelines state do not offer adjuvant sunitinib following surgical resected high-risk clear cell carcinoma. Also, there was major disagreement in the NCCN guideline panels about whether adjuvant sunitinib is appropriate. If adjuvant sunitinib is utilized, it should be probably to restrict the patients with clear cell carcinoma because STRACE only study clear cell ERS. Then we come to hyperfiltration renal injury. When functional renal tissue is removed, glomerular hyperinflations occur in the remaining tissue to restore filtration capacity. Prolonged glomerular hyperfiltration may cause renal injury. This injury leads to focused segmental glomerulosclerosis and progressive renal failure. Hyperfiltration injury might take more than 10 years to develop. Proteinuria is the harbingers of hyperfiltration renal injury. Therefore, if procedures pathological and clinical evidence of renal damage, if more than 75% of the functional renal tissue is removed, hyperfiltration renal injury is more likely to occur. When less than or equal 50% of functional renal tissue is removed, hyperfiltration injury uncommon. For example, after nephrectomy in the kidney donors, glomerular filtration rates does not decline significantly within 20 years of follow-up. Factors that increase the risk of hyperfiltration injury include removal of more than 75% of the functional renal mass, and high protein diet, and obesity, and steroid use, and hypertension, and hyperlipidemia, plus poor controlled diabetes mellitus. All this is considered factor increased risk of hyperfiltration injury. Way of reducing the risk of hyperfiltration injury. Angiotensin converting enzyme inhibitor may help prevent hyperfiltration injury by lowering intraglomerular pressure. Some suggest beginning on ACE inhibitor if 24-hour urine protein is more than 150 milligram. If the 24-hour urine protein more than 150 milligram, we can start ACE inhibitor. Weight loss in obese patients. This is also another way. Lower protein, low sodium diet. Strict control of diabetes and hypertension and hyperlipidemia. Avoid steroid use. Avoid nephrotoxin drugs such as NSAID. This is the end of renal tumor part 2. Thank you very much.